Good evening, everyone. Welcome to Zon's webinar, VetCAT. Tonight's our VetCAT webinar featuring our guest speaker, Dr. Jamie Berning. Comment?
Thank you, Dr. Berning, for joining us tonight. It's an honor and a pleasure. Thank you for taking the time. And Dr. Berning and I have had the chance to know each other for several years now. While she was a resident, she's a rising star in her field now, a board-certified veterinary dentist. She served the community in Ohio, all over the region, and she's well known, well respected. And her research, which we'll present tonight, is really has a huge impact on the practice of veterinary dentistry. So it's really an honor and a pleasure to have you tonight. Thank you, Dr. Berning.
Can see everything fine. So a little bit about me. I'm Jamie Berning, as they just said. I graduated from Ohio State in 2011. I went on to work in general practice, small animal general practice in Southeast Michigan for a couple of years, and then began shadowing a veterinary dentist, Dr. Ruth Barthel, who turned into my mentor. I started my veterinary dental residency in 2013 through 2017. And then I credentialed 2018 and became boarded in 2019. So I moved back to Columbus in 2017 and started a mobile veterinary dental service, traveling all over the state of Ohio, and have a veterinary technician who travels with me, who's actually sitting for her VTS dentistry exam tomorrow morning. And then excitingly, my big news is that I am going away from mobile practice and actually going to be setting up a building of my own, Veterinary Dentistry and Oral Surgery of Ohio, in Columbus. And the main driving force for that is actually the VetCAT. So I feel very, very passionately about having cone beam CT on site. And that was a huge reason why I wanted to be in my own facility. So a few things about the pictures that I put up here, just so I can get to know you all, or you can get to know me, I guess. The one on the top left you'll see is what I thought I was going to do with my life and my career. I spent all of undergrad and all of veterinary school focused on pigs and pigs only. I spent a lot of time opting out of small animal rotations so that I could spend months at a time in Iowa studying just pigs and only pigs. Lo and behold, that is not what I do at all. I don't examine pigs at all. The picture next to that is taken quite some time ago. So that's a picture of David and I at the Columbus Zoo when he came down with a VetCAT to work on a kangaroo and a wolverine with me. So that was a really fun experience. I think that was early 2017, maybe, or early 2018. And then my little girl, Leah, in the bottom right. And then, of course, a picture of, it's not all puppies and kittens, but I sure do love what I do. So very exciting tonight. I'm actually talking about my two favorite things, which is the mandibular first molar tooth, which is my absolute most favorite tooth, and cone beam CT. So when we talk about the mandibular molar teeth, prior to the research that I did, what we knew was that the tooth roots could vary in location. They are carnasal teeth, so they are important for grinding and chewing food. We know that the mesial or most forward portion of that root is more shaped like the premolar teeth, so it's going to be more for the shearing, and then the back side of the tooth, or the distal aspect of that crown, is going to be more for the chewing or occlusal surface there. So it's a two-rooted tooth, and the mesial root is known to be larger than the distal root, and it is very commonly involved in veterinary dental procedures. So we see a lot of periodontal disease associated with the mandibular first molar tooth, and we see fractures there. And these are just a few radiographs from clinical practice. It took me almost no time at all to pull up lots and lots of pictures of teeth, 409 and 309. So those are just a few that we see. So what is cone beam CT? Cone beam CT, for anybody who's not familiar, because I know we kind of have a mixed audience tonight. We have some boarded dentists and we have some general practitioners. I saw some vet techs mixed in here. So just to kind of give a little bit of background for anybody who's not completely familiar with it, cone beam CT is where we have an X-ray source on one side, a flat detector on the other side. It goes one rotation around the patient and acquires hundreds of projections in that time. In veterinary medicine for the VetCAT, we have a relatively large field of view, and it has a voxel size, and that's basically like a little tiny cube. And the voxel size can be as low as 0.1 millimeter, which is a limitation on these detectors. They can manufacture smaller sizes of that, but it doesn't necessarily give us additional information. It does give us 3D imaging, of course. That's what we're looking for. So we have multiple planes of view, so our sagittal, our transverse, and our axial views, as well as 3D reconstruction, which is fantastic. And then you can manipulate the positioning in 3 dimensions after the fact. So I just have a little video here to give you a quick appreciation for what a scan looks like with a VetCAT. And you can see this is just going to give us our scout view. It just gives us a really quick scan. It doesn't take a long time. It's not like a conventional or helical CT where we're using a lot lower doses of everything, and it's much faster for this. So that is just a quick little video for you there. So now I'll get into my research, and I'll tell you a little bit about the background of why I started this research. Is that when I got to know David, because I was working in Ann Arbor at the time, and I had met him at a dental forum and introduced myself. And then I had written to say, hey, I would be interested in learning more about cone beam CT. I think this technology is absolutely fascinating. And he said, okay, come over anytime. And he meant it. And so I started going there on days that I wasn't working, and he spent hours, literally hours, each time I was there teaching me the ins and outs of everything associated with cone beam CT. At the time, it was quite early on for the VetCAT, and there were not a lot of them out in the world like there are now. And so we actually even looked at some human scans. And then we did look at the veterinary scans that he had available. And every time we started going through the veterinary scans, something drew me to the location of the mandibular first molar tooth roots. And I would point it out to David over and over again. And he said, you know, that would be a fantastic research project to do. And I was in clinical practice, not in an academic residency, but I decided to take on quite a large research project of my own, where we scanned 101 cadaver dogs, which is quite a lot to do. Very, very time consuming, but totally worth it. We confirmed all dogs to be mesatocephalic. That was confirmed with the facial indices. And then a series of measurements were taken in transverse view. So this is going to show you if we are looking at, we named these 0, 1, 2, and 3. So that is the relationship between the apex and the mandibular canal. So this would be our apex, or the tip of the root of the tooth, and this would be our mandibular canal. So 0 position would be when we have the apex completely sitting dorsal to this mandibular canal. And then position 1 is going to be when we have anything up to 50% overlap with the mandibular canal. So you can see that we have this tooth root sitting right here, and it's not quite to 50% if we were looking at the cutoff there. Then this would be our position 2 over here. So this is when we have our tooth root overlapping our mandibular canal here. And when we have that overlap, it's more than 50%, but not extending beyond the mandibular canal. So then we have our teeth that do extend beyond. So position 0, 1, 2, and that makes this 3. So position 3 is when our apex does actually extend beyond the mandibular canal here. So you can see what that looks like. So when we look at the bone height to root length ratio in comparison to those tooth roots and where their position is 0, 1, 2, and 3, we can see that if our ratio is higher, so that what that's going to mean is that we have our bigger dogs, and I'll show you this again in a minute, with the bigger dogs where the tooth root itself is actually smaller than the size of the whole mandible, basically is what that's saying. So then we're going to see a decrease as that goes down. And I put this in here so that you can see a lot of the pictures that I show are the zoomed in view where we're just looking specifically at this tooth root, but you can see that, you know, we have the mandibular canal here, and then we have our tooth root right next to it. So if we are looking at a radiograph, which is something that pretty much everybody can do in general practice now, and if you can't, I suggest getting the ability to do that. Dental radiographs are pretty much the standard of care in any general practice now. So when you take a radiograph, you can see basically those positions that we were just talking about. So you can see the mandibular canal right here, or you can see it running kind of over here. And I put both of these in here just so you could see we had this as well. But you can tell that we have all three of the position, or all four of the positions. So right here would be position 0. We would have a 1, a 2, and then a 3. So no overlap at all right here with that mandibular canal. We have a little bit, but certainly not more than 50% overlap with that mandibular canal. Here we have 50% or more, but not going past that mandibular canal. And then here we have it actually extending beyond the mandibular canal. So we can see when we look back at these, we can actually see 1, 2, 3, and 4 positions when we look at it like this. However, what we can't see is where is that tooth root actually in relation to the mandibular canal when we're looking at the buccal and lingual cortices. So if you look here, you can see that this would be our lingual cortex here, and then this would be the buccal. And so you can see that this tooth root is actually on the inside of this mandibular canal here. And so this would be an example here, if this is the buccal aspect, and the same thing here, this would be the buccal aspect. So this tooth is actually on the buccal aspect of this mandibular canal. This one is on the lingual aspect. So we started to look through these, and this is the kind of image that every time when David and I were going through it, I could not get past how significant this was and that it had not been yet described in the literature. So I sought out to try to do such a thing. What we did was also then label, instead of just 1, 2, 3, and 4, where we're looking at relationship of where it is in above or below, we were looking at B being the apex is dorsal or adjacent to the mandibular canal, but it's closer to the buccal cortex. L would be where the apex is dorsal or adjacent to the mandibular canal, but it's closer to the lingual cortex. And then A would be that it was dorsal to the mandibular canal, but equidistant from buccal and lingual surfaces. So kind of stops right in the middle here. So it's dorsal like this one is, and then stops exactly in the middle. And actual measurements were taken from the height of the mandibular bone, the tooth root itself, that's how we got that ratio. And then measurements were taken across to see which side it was closer to as well. So lots and lots of measurements taken on all of these. And then M was the apex actually being inside of the mandibular canal, which sounds crazy, but we did need to include that. So that's what this is. So if you're looking at it here, you can't tell because it looks like it kind of stops, but if you look at it here, you can actually see it is going into and laying right on that mandibular canal. So what we found was that hang on one second, let me open these crackers for this little child next to me. What we found was that 73.3% of the teeth had both mesial and distal roots in the lingual position relative to the mandibular canal. And that's pretty significant. That's pretty significant in that we're saying 3/4 of the time that tooth root is actually inside of the mandibular canal. So 329 roots were in that position L, 71 were in position A. So if you remember, position A was where we were above or dorsal to that mandibular canal and then equidistant. So if we're not lingual, then the next biggest group is that we're just sitting right in the middle. Only 2 roots in this entire study were actually on the buccal aspect of that mandibular canal, and then 2 roots were also in that M right inside of the mandibular canal position. And then as far as the apical positioning goes, 134 were in position 0, 184 with position 1, 62 in position 2, and then 24 in position 3. And then there was consistency between the mesial and distal roots 52% of the time. And when there wasn't consistency, what that was is that since that we know that that mesial root is actually significantly larger than the distal root, we would see maybe the mesial root was going to be in position 1 and then the distal root would be in position 0 is what we were looking at with that. So that was not a surprising result, but the 73% of the roots on the lingual position relative to the mandibular canal is pretty important thing to know about. So the average mandibular height that we found in this study was 22.2 millimeters. It ranged from 10 to 33. And then the average root length was 13.5, and it ranged from 6.8 to 21.4. And that's in millimeters. And then the average ratio, as I talked about earlier, this is that same table, decreased when we look at the apical positions from 0 to 3, which makes sense when you think about it. So a clinical example of why this is really, really important. This is a case that was referred to me. This was a little Chihuahua, and it was not this exact Chihuahua. This is my friend's Chihuahua, but this is a little Chihuahua that was referred to me because when the procedure was initially done, this tooth needed to come out, the root tips broke off, and it wouldn't stop bleeding. And the referring veterinarian could not get this bleeding to stop until finally she just gave up on getting the roots out and said, we're just going to call Jamie, she can take care of this. So, which is fine, and we did. But we take this picture and we say, well, okay, here is where we should have our bundle going, right? Our neurovascular bundle should be going right here. And you can see the reason that it was bleeding probably quite significantly is that we actually cut into that and remove plenty of bone in the attempt to get to these roots. And so what I did then, because I didn't have a VetCAT on site, I was in my mobile practice here, was able to try to take kind of a straight on DVVD type of view here to see, okay, well, these tooth roots are indeed closer to the lingual aspect, which I could see here. And so I open everything up and I'm looking, here is our neurovascular bundle right here. You can see it pretty clearly. Here's where it's going in. So this right here is the same thing as this right here. So that is why, and this is where I took out a tooth root, and this is where I took out a tooth root. And these are those tooth roots. Okay, and this is the after right here. And for all of the veterinary dentists, yes, you have done this plenty of times, but for our general practitioners that are in this group tonight, I want you to just recognize and realize how important this anatomy is in being able to identify how closely related this neurovascular bundle is to these tooth roots. And if they break off, and what you do, this is the buccal aspect over here. If what you do is come at this to take away the bone over here, you're going to be drilling literally right through the mandibular canal before you get to the tooth root. So that is why this is so, so important to understand where this is located in relationship to these tooth roots. So a few things like what I just said, but the smaller the height of the mandible, the greater the likelihood of overlap of those tooth roots. That was what we talked about with that ratio. 73% of these roots are in the lingual position compared to that mandibular canal. It is so important that you do not just take away bone from the buccal aspect if you're trying to get to retained tooth roots that are in there. Be very, very careful and mindful of that mandibular canal. The other thing is, if we're doing surgical endodontic therapy, and I know when, for instance, when I was practicing for boards, this was always the case because we would practice on these exact teeth. And it would be very easy to find the mandibular canal when you make your little window there. And the reason for that is because most often the tooth root's on the other side of that. So 3D imaging would be ideal. So for all the veterinary dentists out there, if you don't already have a cone beam CT in your practice, I would strongly recommend it. It's a wonderful, wonderful thing. And then I just wanted to say a few more things real quick is that this is when I used to kind of spend all of my time at Zoran, and it became like a second home to me. It truly was like a second home to me, in that this was the doors that I walked through. This was my little workstation here. And then this was actually what my workstation looks like. And that's David's daughter taking care of my daughter when she was quite little. And that's them there. So I just want to say thank you to everyone for choosing to attend this lecture today. Your time's valuable, and I really appreciate you taking your time to make the choice to be here. Thank you to Zoran, to Dental Focus for hosting this, facilitating this meeting, David and Jim for everything, Chris and Scott, and everybody out there who trust me with their patients and their pets. So at this point, I will take questions.
Thank you, Dr. Berning. I think we have one in the chat room. Any practical tips for extraction of 309/409?
Yes, I have all kinds of tips for extraction of that tooth, but that I don't have them in a way that I could easily put them into just words. Mostly not applying prying forces, trying to avoid that, and more kind of twisting rotational forces, gentle forces. But I'm not sure who asked the question, but if they send me an email or a message, I would be happy to send them some videos or tips and tricks of things that I do regularly that work quite well.
That question was from Erin Bond. I'll share her email with you.
Okay, great. Thank you.
Dr. Canfield asked if CBCT has changed your approach to flap and bone removal to lingual instead of vocal based on root origin.
So I try to only take bone from up above when I'm removing tooth roots. I try to not remove a lot of bone from the buccal aspect anyway. And actually, I am just going to be getting cone beam CT in my practice. So it is possible that it will change my approach. It's going to be a fantastic tool to have available. I imagine that I'll still do a lot of approach still from the top, but it's possible that I may get creative when I can see things in 3D.
There's another question here. In your research, were left and right consistent, or was it very much tooth specific or site specific?
Can you say that again?
Were the left and the right, in other words, if you had a finding on one side, would you find the same? Would you have the same finding symmetrically, or
yes.
is it very much tooth specific?
Yes, and I thought I had put that in there, but I guess I didn't. So 96% of the mesial roots and 97% of the distal roots, I believe it was, is consistent between right and left. So almost every time, same.
And another question here, with regard to the technique itself of extractions, once you know where the root's apex and as a result, the angle of the root is positioned, would that influence your extraction technique in a sense that your axis of rotation might evolve?
Oh yeah, I think absolutely, because then you could see if you have dilaceration or curvature of your root, you could see it if it was in a plane other than what you can view on just a radiograph, because I think that happens all the time where I take out a root that looks straight on a radiograph, but actually wrapped itself around in maybe a little bit of a twist or a turn at the tip. And so I think absolutely to be conscious of where that is in order to extract in a plane that's going to accommodate not breaking that would be a very important thing.
Very interesting. I think this is really a very impactful research, and you've gone at it in a very scientific way. It really has an influence on approaches for procedures, like you said, endodontics and extraction procedures. But going forward, it's really going to change the way we approach that tooth in particular, and probably influence some others to sort of move on to the next research, so to speak. And where are your thoughts about, what other areas might have the same issues? You focus on one particular area. What else would you consider?
Sure. I mean, I would love to, without the limitations of what we had on this study, which was that we didn't have the ability to know the body weight of these patients, right? Because they were cadavers. And so I would love to do a clinical study where we're actually able to map out that mandibular canal a little bit more thoroughly, looking at skull type and size of patient. That would give us the ability to have a little bit more predictability, I think. Because we don't know consistently where it is, or if it's even consistent, in the wide variety of animals that we see.
Very, very interesting. There's another question here. Where is this research published?
It is published in Frontiers, and it is available. You can click on the link. We can send it out or make sure that you can get access to that. And there's no subscription or anything necessary. You can just read it.
Yeah, I think you had the reference somewhere on one of the slides, so we'll be sure to share.
Yeah, I do. Yeah, it was on there.
Mm-hmm. Yeah, that's great. You made a reference. This is my question for me. You made a reference to endodontic treatment, and so how would the relationship of the roots to the mandibular canal be influence the endodontic treatments?
I think that it would depend on what your goal was, where your root exactly was overlapping with the mandibular canal, and if you felt that you could easily still access it from one side, or if it was very, very close to the lingual cortex, if it was easier to do your approach from that side within reason, depending on if you could get in there with the tongue and everything, because it's so far back in the mouth. I think that it's going to be a matter of getting more 3D imaging to find out with surgical endo cases in particular. We don't do them very frequently. They're a less common procedure, but I would say it would be really nice to have 3D imaging, and if it's going to be an easier approach to do your surgical endo from a lingual aspect, maybe that's a consideration.
Great, yes, thank you. Lots of questions. There's one more here from Dr. Angel. How would you extrapolate your findings to brachycephalic breeds?
Yeah, that's a great question. So I don't know. Everything that we did in this study is mesatocephalic, and so I can't say whether or not it's consistent if we have different skull types. I would love to know. I would love to find out, and maybe I will soon. We'll see.
Another question here also from Dr. Canfield. 109 and 209 viewed by CBCT is an additional area of interest with regards to root apex and orbit. Did you have an impression from this in the images you reviewed for your publication?
Yeah, I mean, yes, I understand and appreciate that question. I didn't focus on those teeth specifically, so I can't comment on any specific measurements for that area, but there are definitely lots of specific teeth in the mouth that would be worth looking at, especially in the caudal maxillary region, in order to determine what's normal and what everything is like there.
I think Dr. Canfield might have volunteered to do a little research himself here.
I thought that I had heard of somebody who was actually doing that project, a veterinary dental resident, but it's been about 2 years ago now, I think, so I'm not sure if that ever came to fruition or not.
Very good. Well, thank you very much. I think that answers all of the questions I can see here. Again, thank you so much for taking the time to organizing this beautiful presentation. Very insightful.
Yeah, thank you for everybody for coming and for hosting.
Yes, thank you so much. I see a lot of thank yous in the chat notes here. We appreciate the beautiful research. I can attest to many hours and long days you've spent with us doing those measurements. This was an amazing amount of hard work and beautifully put together. I think the publication is very interesting. So thank you very much. Thank you to all of the attendees for spending the time with us. And we look forward to having you again for the next presentation. Thank you again, Dr. Berning, for this beautiful presentation.
Great job, Jamie. Thanks.
Thank you. Have a wonderful evening, everyone.
Thank you.